All right, so welcome everyone. Thank you guys for joining us this morning. I'm here to talk about a cheap complaint that probably a few of you here in the audience have seen before. I know at least in my institution, opiate overdoses or bad reactions seems to be vying for number one in terms of visits. But a few of you have probably taken care of somebody with chest pain before, right? And so it's super common, over 5 million ED visits a year. And when you look at the numbers, it's about the second most common ED complaint. Like I said, opiate overdose seems to be vying for number one in my shop, but chest pain is super, super common. And we know that it can be bad. Coronary disease is the leading killer in the US. They roughly estimate about 25%. I think that may be a bit of an overestimation, but it's still a bad player. And so we don't want to miss the serious causes of chest pain. We don't want to miss acute coronary syndromes. And it's a huge burden for the hospitals as well. It's up to 25% of all hospital admissions, chest pain and acute coronary syndrome. But when you look at the discharge diagnosis, it doesn't actually pan out that way. Up to 85% of them do not end up with a discharge diagnosis of acute coronary syndrome. So what it means is we're admitting a ton of patients for something that we're really worried about, but at the end of the day, most of them don't end up having it. So it puts us in a bit of a conundrum, because if we miss it, bad things happen. All right. This was an older study that looked at ED patients being admitted for chest pain. And despite all of our diagnostic testing, we still end up missing it. And when we miss it, bad things happen. Patients die. And unfortunately, the big professional organizations aren't really helping us much in this regard, or at least they haven't historically in the past. So the American Heart Association and American College of Cardiology, when they came out with their guidelines, if you're having a STEMI, that's great. It's a very clear-cut pathway. Nobody argues with that. But it's the whole NSTEMI and acute coronary syndrome pathway that we really struggle with. And when they came up with their guidelines, basically they put us in a really tough place, because they said anyone that you're considering discharging, you should be getting provocative testing within 72 hours. And I don't know about you. In some systems, I think that is maybe feasible, but it's certainly not in my system. I work in an inner city hospital with a disenfranchised patient population who don't have a lot of resources. They don't have good primary care follow-up. So realistically, getting them that provocative testing in 72 hours is really challenging for a lot of our patients. And at the end of the day, is even actually really needed. And so when you look at the algorithm that the professional societies have come up with, again, STEMI, pretty clear cut. You go right down the algorithm, you go right to reperfusion therapy. For NSTEMI, if they end up having positive biomarkers or an abnormal EKG, again, fairly clear cut. They get steered right into the cardiology service and they take it from there. But it's that whole group, and I would say that's probably the majority, where they have sort of negative or equivocal EKGs, negative biomarkers, and then we're left with the question of what do we do with them? And since the mid 2000s, 2010 and so and beyond, most of them are recommended to get provocative testing. Thankfully, they're starting to come around a little bit. I think they've started to realize that they put us in a real sort of bind here. And if you read the fine print, I'm not going to go through the whole thing, they basically acknowledge that in their guidelines for NSTEMI and acute coronary syndrome, although they mention chest pain, they don't really tell us much what to do with it. And so they've actually started to commission a working group to help us out, comprised of emergency physicians, primary care providers, to try and come up with a reasonable strategy for what to do with these low-risk chest pain patients. We're not there yet, or at least they haven't given us anything yet. And so, again, it puts us between a rock and a hard place with these patients. If we miss acute coronary syndrome, we know the patients tend to do badly, all right, and nobody wants that. If we do too much testing, on the other hand, we also know the patients don't do well, all right? We're exposing them to increased radiation, a lot of false positives. They end up getting invasive testing when they may not need it. And so it really is sort of a tough spot that we're in when it comes to these low-risk, not clear-cut acute coronary syndrome patients. And so at the end of the day, we're striving for the Holy Grail, and we want sort of the magic bullet answer. And what are we looking for? Well, obviously, we don't want to miss acute coronary syndrome in anyone. That's obvious. We want to know how to appropriately dispo these patients. Who can we safely send home? Who needs to be admitted, a full admit to the hospital? Who can we safely put in our chest pain observation units? Just as a quick show of hands, how many people here have an observation unit for chest pain in their EDs? So a reasonable number. I have to admit, we've had ours running for well over a decade now. And when it first started, I was very resistant to the idea. And I've actually come full 180. I think ED-based observation units are a phenomenal thing. It gives us a lot of control over the care of our patients, and I think saves them a lot of time in the end as well. So if you don't have one in your institution, it's worth maybe bringing the subject up with your hospital administration. They will love you for it, I guarantee. And then we want to figure out which patients actually don't need anything at all. So not every patient that comes in with a twinge of chest pain needs to get a full-on stress test, certainly not within 72 hours. So looking at what our priorities as emergency clinicians are, we need to decide, is this really ACS or not? All right, and not every patient that comes in with any sort of twinge from here to here needs a workup. Are there clinical features that we can look at to help us decide what the patient's risk is? And when it comes to risk factors, what is the actual role of cardiac risk factors? Do they matter or not? And what role does the EKG have? Again, it's really easy if they're having a STEMI, all right? You're off to the races, nobody's gonna argue with that. But in the absence of that, what role does the EKG actually play? So just to get some definitional things out there and get some issues on the table, when we look at studies to help us determine people at risk for ACS, one of the big things we look at is outcome measures, and sort of the common terminology out there is a MACE, which is a major adverse cardiac event, and that includes things like death, emergent revascularization, or an acute MI. And that's sort of the standard primary outcomes that we look at in these studies. The time to outcome measurement should be reasonable, all right? If they're looking at outcomes 5 years down the line, that doesn't really apply to us. Similarly, if they're looking at outcomes like a week out, that also doesn't really help us very much. That doesn't put us out of any sort of danger zone. So we need some sort of reasonable time frame for outcome measurement. And whether that's 30 days, 60 days, a year, nobody really knows. But I would argue that we should at least be looking at 30-day outcomes. And then we need to use a scoring system that is widely available to everyone, that uses tools that everyone has. And so troponin is sort of a nice, easy one that we can use. Some other issues and definitions. When we look at some of these protocols, we call them accelerated diagnostic protocols, or pathways, ADPs. Again, quick show of hands, who here is actively using an ADP in their department to evaluate chest pain? So only a few. So again, this is something, as we go through this, take some notes and bring it back to your hospital administration, because if you can adopt one of these as a system, you'll find that it will really sort of streamline the care for these patients. In order for these to be actually useful, though, is that they need to be externally validated, and they need to be validated across a variety of different types of health systems. You know, my health system is very different than some of the health systems in California in terms of follow-up care, and that really changes the dynamic and can potentially change outcomes. So whatever protocol you're using, you want to make sure that it fits across a variety of different healthcare systems. So do they exist? Are there pathways out there or scoring systems that we can use that actually work? And the answer is sort of yes and sort of no, but it looks very promising. So the first one that always gets brought up is the TIMI score. So the cardiologists love them a TIMI score. And basically, this is it. And if you look at it, I have some serious issues with the TIMI score. And there's a reason why we don't tend to use it very much in the ED. It looks at some really funny things like aspirin in the last 7 days. And I know the rationale for it. They're saying that if they're already on aspirin therapy and they're having acute coronary syndrome on top of that, that puts them at risk. But there are a lot of people out there on aspirin who have no coronary disease. It's just their primary, put them on it because it sounds like a good idea. So that doesn't really help us in the emergency department. Another thing is it looks for the presence of risk factors. And I don't know about your shop, but a lot of the people in my place, when they come in, they're an obese 64-year-old guy, and I'm like, do you have any cardiac risk factors? And they're like, no, I'm healthy as a horse. I'm like, well, when was the last time you actually saw a doctor? And they're like, I don't know, 40 years ago. I'm like, so you certainly don't have high blood pressure, high cholesterol, diabetes, and all the other stuff, right? So that doesn't really help us, you know, the absence of known risk factors. If they have them, great. The other thing is when we look at the numbers don't add up either. So even at a TIMI risk score of 0 to 1, which is considered fairly low risk, they still have a 4.7 chance of having a MACE essentially at 14 days after randomization. And those numbers are just way too high, particularly in this country. All right, that's not an acceptable miss rate. So enter the heart score. And the heart score has been around for a while. It's been around for over a decade now, originally derived in 2008. And the beauty of the heart score is it has actually been validated externally in a variety of different systems. And it's been found to work with women, who we know tend to present sort of atypically. It works in diabetics. It works in the elderly. It works across different ethnicities. And it uses things that are widely available in pretty much every ED in the country, like troponin. So I'm, in general, not a big fan of eponyms because I think they tend to force them and they're kind of silly, but the heart score actually sort of works. And so what the heart score stands for is history, E is for EKG, A is for age, R is for risk factors, and T is for troponin. So it's pretty easy to remember. It's on, you can just Google heart score calculator and you'll pop up 20 different things on the computer if you forget what all the elements are. So it's very easily accessible. And when we take a closer look at it, when we look at the history, this is my one gripe with it, is it adds a little bit of subjectivity into it. And whenever you're looking at clinical decision rules, sort of the ideal is one that's completely objective, like a yes-no answer. And that's why things like the PERC rule work really well, because it's a very objective scoring system. The heart score does have a little bit of subjectivity in it, and it asks you to decide whether their presentation is highly suspicious, moderately suspicious, or slightly suspicious. The beauty of it is it's a difference of 1 to 2 points. It's not going to totally skew the score one way or the other, but they also give you some things to help you decide some more objective things about whether it's considered a high-risk or low-risk presentation. Things like, is the pain pleuritic? Is it so localized that they can point with one finger to where the pain is? Is it reproducible with movement, or palpation? I would caution you, there was a study many years ago in the New England Journal that looked at reproducible chest pain, and up to 40% of patients with reproducible chest pain actually had a cardiac etiology. So I wouldn't use that in isolation. Brief episodes that are self-terminated, they last a few seconds or less. That's not really typical for cardiac chest pain. Maximal intensity at onset, and then radiation to the lower extremities. This one I also find a little concerning, not necessarily for a cardiac etiology, but if you're around in the afternoon, I'm going to talk about some other high-risk causes of chest pain. And I would argue if you're having chest pain that radiates down into your legs, that would get my attention for some other possibilities like a dissection. But regardless, it does give you a little bit of guidance in terms of deciding whether it's high risk or not. The next thing is the EKG. And basically what we're looking at is big things. So if they're having significant ST deviation, so if they're having a STEMI, that's obvious. They're outside the pathway. They're going down the whole STEMI pathway. But if they're having a millimeter or more of ST depression and contiguous leads, that's considered significant, and that's going to get you a score of 2. If they're having nonspecific things, like some nonspecific repolarization abnormalities, a bundle branch block, anything like that, it gets them a 1. If it's totally normal, you get a 0. Age, I'm hoping that for most people isn't a struggle. I'd say that's probably fairly objective. In terms of risk factors, so again, it brings in that idea of risk factors. Again, I'm a bit of a skeptic in that a lot of our patients, at least my patients, don't necessarily know what risk factors they have. But the presence of them certainly will get you points. They also sort of go through some of the risk factors, and they're all the things that we typically think about, but they also add in obesity, which is not present in a lot of other decision rules. And then finally, troponin. And again, that's a fairly objective measure across shops. What is troponin? So this is sort of basic science review. So it's a protein that's found pretty much only in myocytes, and it's a marker of myocyte necrosis. Depending on which assay you use and which type of troponin, you can see a rise as early as 2 hours after symptom onset. The problem with troponin is it lasts for a while. It takes a while to clear. And so when you have a patient who came in with an NSTEMI like 3 weeks ago, and they're coming in now with recurrent chest pain and they have a mildly bumped troponin, the question is, are they still downtrending from their prior event, or are they on their way up? So that's a whole different story. And there are some prognostic indicators in it as well. The higher the troponin tends to indicate a bigger infarct and increased mortality. The problem with troponin is, even though it's specific to the cardiac myocytes, there are a lot of things that can cause an elevated troponin. And especially now that we're measuring it in the thousands of a unit, we're getting to the point where, you can exercise a little bit too much and maybe have a tiny little bump troponin. So you got to take it in the clinical context. This is sort of showing the evolution of where troponin came from. Over the years, it's become more and more sensitive. We're able to pick it up earlier and earlier. Before, it used to be we never even checked before 8 hours. Now we're checking it at time 0 and basically 2 to 3 hours, which is helpful for us. There's this whole idea of ultrasensitive troponins. And so again, they are measuring these in just such small, minuscule amounts. The problem with that is, yes, they're incredibly sensitive for acute coronary syndromes, 100% sensitive. But the problem is when you measure something that low, yes, your sensitivity is going to be high, but your specificity goes right out the door, as is your positive predictive value. So if we were to measure ultrasensitive troponins in this room, I would guarantee that a huge number of you would probably be positive. And I'm hoping that none of you are having an acute coronary syndrome right now. So my take on it is they're not ready for prime time. I don't think they're all that useful for us. I think it's going to create a lot more false positives than they're worth. So how good is the heart score? It turns out that when you look at the numbers, a heart score of 3 seems to be the break point. And at a heart score of 3 or less, your chance of having a major adverse cardiac event at 30 days is very, very low. And so that's sort of the break point between what we would consider a low-risk patient and a moderate to higher risk patient. At a heart score of 9 or 10, your chance of having a MACE is incredibly high. So those are high-risk patients. What is the actual number? So at 6 weeks, it's about 1.7%, which is good, but we know that, in terms of sort of general medical concepts, a miss rate of less than 2% is pretty good. In terms of the general public, missing an MI, we're looking for 0. Are we ever going to get to 0? No, but we got to try and get it as low as we possibly can. And can we do that? And the answer is yes. So what this group came up with is they took the heart score and they added a second troponin to it. You'll notice in the initial heart score, it's just a single troponin. So what this group did is they added a second troponin to it to see if they could increase the diagnostic accuracy. And basically what it is an initial troponin at arrival and then another troponin at 3 hours into it, so a 0 and 3 hour troponin. And what they found is that if both were negative in an otherwise low-risk patient, that the risk dropped to under 1% at 30 days. And I would argue that, at least at this stage of the game, that might be as good as we're going to get it. And what that would also suggest is, do we need to even keep these patients? Are they so low risk that we can actually discharge them from the ED? And so when they looked at it, up to 20% of the patients, these low-risk patients, met criteria, and they were able to be discharged early from the department. And here's sort of a graph looking on the left is the heart pathway compared to usual care, so what we would normally do with chest pain patients coming in. And they performed fairly similarly. But when you separate out the heart score patients, those who are high risk and low risk, you'll see a huge benefit in the low risk patients here, all right, in terms of who we can discharge early. There's a big dichotomy there. And when you look at it, we were able to significantly decrease the number of patients who got cardiac testing with the heart score, 57% versus 69%. Significantly increase the number of patients that we could discharge early from the ED. The length of stay also decreased, although it was not significantly, statistically significant. There was definitely a trend towards early discharge. And great sensitivity. The specificity is okay, but in terms of what we're looking for, we don't want to miss an ACS patient, and so it performed very well in that regard. So now the question is, in terms of outcome measures, looking out further, how does it do? And so this group took and they randomized patients to either the heart pathway or usual care, and they followed them out to a year. And I think for emergency medicine, that's probably a pretty decent interval in terms of outcome measures. And what they found, they looked at 282 patients with chest pain, and they randomized them to either the heart pathway or usual care. And they looked at things like the incidence of MACE. They looked at the amount of objective testing that was done on these patients. They looked at cardiac hospitalizations and also ED visits. So all things that are sort of pertinent in terms of healthcare resources. And what they found was that among that low-risk cohort, so a heart score of 3 or less, their incidence of MACE at 1 year was 0%, which is pretty darn good, all right? When they looked at all the other variables, things like objective testing, hospitalization, ED visits, there was no actual difference in it. So what that tells me is in the right cohort of patients, in a low-risk heart score patient with a 0 and 3-hour negative troponin, we can safely discharge them home and feel pretty good about doing that. We don't have to bring all those patients into the hospital. Obviously, if their troponin at any point is positive, that's an easy, you admit them. And then if they're less than 3 or less in a low-risk patient, you can feel pretty comfortable about sending them home. The question is whether or not they even need to get further testing at that point. We're going to talk about some abstracts later in the morning that would suggest probably not. And so this is sort of a graphic pathway or representation of the heart pathway. And basically, if they're low risk, negative serial troponins, negative EKG, they can go home. Important to note, though, that even though the risk is under 1%, it's not 0. I don't think anything in medicine is really 0. We're just not there. So how do we talk to the patients about that? I can tell you that from experience, most of the patients are pretty comfortable with going home, but you want to have sort of an educated conversation with them and make sure they really understand what the risk is. And so there was a group that looked at that and this idea of shared decision making, and they came up with something called the chest pain choice aid to engage patients in their workup. And basically there's 4 parts to it. And the first part is from the start, this is talking about their initial testing, so that they had a negative troponin, their EKG was non-diagnostic, and that their exam and their risk factors and everything else appeared to be fairly low risk. With that, they said, what do you want to do from here? And so they said, if we do some more testing, we can try and reduce your risk a little bit further. And what they're recommending is the additional troponin, the 3-hour troponin. And if they're saying, if that is negative, here's what your risk is. And they graphically lay it out. And I think that's helpful for patients to see, exactly what that looks like. And what they're saying is, you have a less than 1 in 100% chance of having something like a heart attack or another serious outcome if we send you home based on the workup that we've done here in the ED. And then they can decide, do they want to wait the extra 3 hours and get their 3-hour troponin? Or do they want to accept the risk of going home with just a single troponin, knowing that their risk is around now 2%, so it's a little bit higher? And, or do they really prefer to be kept in the hospital for observation and do the full gamut of the workup there? Now, I think there's value in this. I think a low-risk patient, a heart score of 3 or less with negative serial troponins and negative EKG, I would feel pretty strongly about sending them home. And actually, in our institution, I would have a hard time admitting them even to the OBS unit because we've adopted the heart pathway and followed it so closely. So you might, depending on your institution, might want to skew the discussion a little bit one way or the other. But certainly in somebody who wants to go home, you have to have that educated discussion and let them just understand what the risks are. So the key points with this is you need to be a little bit selective in who you're labeling as low-risk chest pain, all right? You have to understand the limitations of risk factors. Patients may have significant risk factors and just not be aware of them. So, I would say if somebody comes in, they're morbidly obese, they're hypertensive in the ED, like significantly hypertensive, I would at least give them the hypertension and obesity as a risk factor. So you got to be a little bit careful in dealing with that. But the heart score has been fairly well validated. It's been adopted in multiple health systems. And in general, I think it's probably one of the best bets we have to decrease the burden on the healthcare system of admitting all of these patients with chest pain. I can tell you in my own institution, in conjunction with our chest pain unit, we've been doing the heart pathway for about 4 years now, and we've had a 0% MACE incidence at 30 days. So it's been very successful for us, and it's really sort of changed the whole chest pain dynamic in terms of how we deal with some of these low-risk patients. And then consider using something like the chest pain choice aid in getting buy-in with your patients and making a fully sort of shared decision model with them. All right, thank you guys.